Hello, Dr. Young. This is Kemal Sayar.
Merhaba Doktor Young, ben Kemal Sayar. İyi günler diliyorum. Toplantımızda bulunmanızdan büyük memnuniyet duyuyoruz. Sıra dışı bir toplantı aslında. Bugün düzenlediğimiz sıra dışı koşullar altında ama çok canlı bir toplantı olarak geçiyor. Değerli katkılarınız sayesinde. Kısa bir şekilde Türkçe olarak takdiminizi yapmak istiyorum.
İngiliz Psikofarmakoloji Cemiyeti'nin uzun süre başkanlığını yapmış olan ve kongremize çok önemli katkılarda bulunmuş geçmişte de ve bugün de katkıda bulunmaya devam eden Profesör Allan Young misafirimiz. Kendisi bize 21. yüzyılda lityum başlıklı bir sunum gerçekleştirecek. Once again, thank you for your
Tekrar teşekkür ediyorum katkılarınız için Doktor Young. Sözü size bırakıyorum. Çok teşekkürler. Çok teşekkür ediyorum konuşma davetiniz için. Her zaman Türkiye'ye gelmek büyük bir memnuniyet benim için. Ancak bu sefer fiziksel olarak katılamadım. Bunun için özür diliyorum. Yine de davetiniz için teşekkürler. Ben Profesör Allan Young, Afektif Bozukluklar Merkezi'nde Psikiyatri, Psikoloji, Nörobilim Enstitüsü'nde King's College Londra'da çalışıyorum. 21. yüzyılda lityumdan bahsedeceğim bugünkü sunumumda. Aynı zamanda tedaviye dirençli depresyondan da bahsedeceğim. Beyanımı paylaşmak istiyorum. King's College Londra'da, İngiltere'de çalışıyorum. Onursal danışmanım Moseley ve Bethlehem hastanelerinde NHS kapsamında. Duygu durum bozuklukları servisinin başkanlığını yapıyorum. Ulusal Efektif Bozukluklar servisinin de aynı şekilde. Ve yeni bir servisimiz de var. Moseley Hastanesi Tedavi Merkezi. Sanayi ile birlikte de çalışıyoruz yakın bir şekilde. Akademisyenler sanayideki ortaklarıyla birlikte çalışarak çok güzel katkılar sağlayabilir ama herhangi doğrudan bir payım, hissem yok. İlaç firmalarında birçok çalışmada yer aldım ve hibeler aldım. Şu ana kadar farklı kurum ve kuruluşlarda da çeşitli görevlerim var. Ulusal enstitülerde ve translasyonel terapötik kümesi yine başkanlığı, Psikofarmakoloji Özel Komitesi'nin eski başkanıyım. Aynı zamanda Efektif Bozukluklar Uluslararası Derneği'nin geçmiş başkanıyım. Ve Psikofarmakoloji, İngiliz Psikofarmakoloji Derneği'nin de geçmiş başkanıyım. Avrupa Psikofarmakoloji Derneği'nin kardeşi diyebiliriz. Öncelikle ruh hastalıklarının maliyetine ve oluşturduğu yüke bakalım. Demans ve ağrı için de bakacak olursak, bu farklı bozukluklar sizin de ekranda görebileceğiniz gibi oldukça fazla bir maliyete sahip. Bel ağrısı en fazla aslında. Küresel olarak dizabilite ile yaşanan yılların en üstte yer alan 25 sebebini görüyoruz. Bel ağrısından sonra majör depresyon yer alıyor ve en büyük hastalık gruplarından ve meselelerden, psikiyatrik meselelerden de birisi diyebiliriz. Kırmızı olarak gösterilenler nörolojik bozukluklar kapsamında yer alanlar, ancak diğerleri de önemli olarak görünüyor. Duygu durum bozuklukları dediğimizde bunlar ikiye ayrılmış durumdadır. Bipolar ve depresif bozukluklar olarak iki grup bulunmaktadır. Bence bu bölünme klinik olarak her zaman faydalı değil. Çünkü klinik açıdan baktığımızda
in fact have much more in common with bipolar disorder than with single episode major depression. but nevertheless, the split is there. The one major change is that dysthymia has been lumped in with chronic depression to be persistent depressive disorder. It's worthwhile noting that bipolar disorders is a group of disorders: bipolar 1, bipolar 2, bipolar not otherwise specified, and cyclothymia. The old concept of manic depressive illness, the Kraepelinian concept, really included recurrent unipolar disorder as well. And of course, 50% of MDD will be one episode only, whereas the other 50% will be recurrent or chronic or unremitting. What about the reliability of these disorders? Well, this is from the DSM-5 field trials published in the American Journal of Psychiatry about 8 years ago. And it's worthwhile actually having a look at this, because this shows, I think, a hierarchy of reliability, certainly for the mood disorders. So the green at the top here is the most reliable, orange is the least. You can see that bipolar 1 is pretty much reliable. It's well ahead of bipolar 2, but that's also well ahead of major depressive disorder. Mixed anxiety depression was essentially not reliable at all. If we also look at this, not only is bipolar 2 more reliable than major depression, but schizoaffective, I think because of the presence of mania, is more reliable than schizophrenia. But bipolar 1 is the most reliable diagnosis, I think, because of mania, which can be misdiagnosed, but that's less likely than misdiagnosing a depressive episode as something else. So what is bipolar disorder? Well, it's a recurrent affective or mood disorder, typically involving both mania and depression. Bipolar 1 is manic or mixed episodes and almost always episodic depressions. Now, there are a group of people with bipolar 1 who only ever have manic episodes, who are never depressed. This was said to me by a patient about 30 years ago. I can recall her saying to me, "I don't know why they call it bipolar, because I've never been depressed in the slightest. I've only ever been manic." And she had had bipolar disorder for about 30 years by that time. We've recently studied this. It seems clear that unipolar mania is commoner in sub-Saharan Africa and the Caribbean, but it does occur in Western European countries like England and France. We recently published on this, although it's a small fraction of bipolar 1s. But it's an interesting concept, really, because it means you can separate mania from unipolar mania from overall bipolar conditions. And I don't think this is entirely due to secondary mania. I think there is a form which is an actual mood disorder, which is recurrent unipolar mania. But most bipolars, the vast majority, will have depressive episodes, and indeed the depressive episodes will predominate. Bipolar 2 is recurrent major depressive episodes with hypomanic episodes, highly likely to be confused with major depressive disorder, and then subsyndromal states, including psychothymia. Two other points, two other terms are worthwhile discussing. Rapid cycling bipolar disorder, at least 4 episodes or 4 switches in polarity in a year. This was really defined by David Dunner and Fivey in the mid-1970s, but really had been described long before then, including by Fauret in France at least 100 years before. And mixed states where people with mania have some depression, or people with depression have some mania, are actually far commoner and captured far better in DSM-5 than in previous iterations of DSM. So this is a schematic derived from the paper by Kathy Merrick-Angus, my friend and colleague in Washington, D.C., at the National Institutes of Mental Health, just describing some of the features of bipolar disorder. So bipolar disorder comprises mania in bipolar 1, hypomania in bipolar 2, depressive episodes, subsyndromal depression, which can be far commoner, and high rates of comorbidity, including substance or alcohol misuse. and of course mixed states where you get manic and depressive symptoms at the same time. Now, I'll come on to talk about this study a bit more, but it's noteworthy that Kathleen reported in this paper that in a 12-month period, about 69% of patients with bipolar 2 and about 75% of patients with bipolar 1 had clinically severe mood episodes. And this means that the need for maintenance, preventative or prophylactic treatment is actually really quite evident in bipolar disorders. And that leads us naturally to lithium. But before we get there, a little bit more about this epidemiological study done by Merrick Angus. Kathleen and I are, with colleagues in King's, are actually reviewing the world literature about epidemiology of bipolar just now, and that paper will hopefully be ready for submission soon. But this, to my mind, is the best individual paper. This was based on looking at over 9,000 English-speaking adults aged over 18 in the United States. Lifetime risk of any bipolar was 4.4, so that's really very common. 12-month period, 2.8. Lifetime risk of bipolar 1, 1%. Bipolar 2, 1.1, so 2.1% overall. And if you include the subsyndromal penumbra, it's 2.4% added to make a total of 4.4, 4.5%. So a very common disorder. Even in the United States, which is probably one of the more medicated countries in general in the world, you find that large numbers of people with bipolar disorder don't receive medication. So in Kathleen's study, she found 47% of people with bipolar 1 weren't on medication, 60% of bipolar 2, and not otherwise specified, about 75%. So despite the clear need for preventative long-term treatment, many of these individuals are not receiving medication. Just to review the natural history, it's frequently early onset before the age of 25, although there is a tail of later onset after 50. The lifetime prevalence I've gone over, 75% of patients with bipolar have psychiatric comorbidity. So this is extraordinary. This means that psychiatric comorbidity is the rule in bipolar disorder rather than the exception. And of course, many of these comorbidities are the reason for an exclusion from clinical trials, particularly substance and alcohol misuse. So Dr. Paul Stokes and I recently reviewed the world literature on people who had bipolar disorder and a comorbid substance or alcohol misuse. And really the only trials that we could find indicative of benefit were for mania. There were no studies suggesting benefits for depression. And I've talked about the recurrent nature of the disorder. So of course we must remember that bipolar disorder rests in a spectrum. The great Hagop Akisko passed away recently and is much missed, but Hagop was foremost in raising psychiatrists' consciousness about this. But if we think about a spectrum, it might go from bipolar 1 or even schizoaffective with increased energy or activity, through to bipolar 2 with increased energy, activity, and so on and so forth, not otherwise specified, to MDD, where there's always the possibility of a progression to bipolar. Remember that 2/3 of bipolar patients will have 2 episodes of depression before any episode of hypomania or mania. So some of the indicative features that may suggest someone with MDD is likely to progress: subthreshold hypomania, satisfying the specifier for mixed features, mood lability or cyclothymia, and some developmental issues such as ADHD. Where do we draw the line between MDD and bipolar? Well, I think if there's certainly agitation of subthreshold hypomania, we should be looking for this. But my view is that every diagnosis of major depressive disorder is provisional. I've seen patients who've been revealed as having bipolar disorder after 25, 30-year histories, apparently, of recurrent depression. Now, we've done work on this. This is from a paper published in Biological Psychiatry. And we showed in a research setting that using diffusion tensor imaging and using a Vauxhall-based meta-analysis, we could show that there were differences in measures such as fractional anisotropy in brain areas such as the left posterior cingulum, and this may differentiate these two conditions. But at the moment, this is not a clinical tool or a practical tool to aid diagnosis. Okay, well, what about treatment? Well, treatment for bipolar disorder should be borne in mind that all psychiatric treatments are subject to skepticism. This is a painting by Hieronymus Bosch, who is a painter from the Low Countries in the UK, a late medieval painter. It's called Extraction of the Stone of Madness, and it just shows a neurosurgical technique for someone who has a psychiatric disorder with religious and academic input. The reason I like to show this is just to show that even though we may think our current treatments are scientifically founded and cutting edge, they may appear to be crude and absurd to future generations. And of course, there is the commercial aspect, the snake oil aspect. And remember, I like to constructively engage with industry. I think commercial aspects are very important. We've seen with the COVID vaccines how companies such as AstraZeneca, Pfizer, and so on were absolutely instrumental in creating these new vaccines in partnership with academics. But we must always be aware that we have to have evidence. We have to have scientific rigor to guard against the snake oil trap. And this is based on the hierarchy of evidence, which really goes from the introductory level being test tube research, animal research, hypothesis generating, case reports, case series, case control studies, cohort studies, and then at the peak, we have randomized double-blind controlled studies and systematic reviews and meta-analyses. Now, the reason I'm showing this and the reason this is important here is because lithium really went up through most of these levels from being discovered as a mineral to animal research done by John Cade, right through to confirmation of its benefits in recent systematic reviews and meta-analysis. So lithium has stood the scientific test of time. And when we think about any treatment, we should be thinking about both benefits and harms. This is true for drugs, it's true for psychotherapies, it's also true for neurostimulation. It should, of course, rest on an accurate diagnosis and identification of all comorbidities. And the benefit between risks, benefits, and harms can be swung by things like concordance, psychological treatment, psychoeducation. And we should be considering this not only in the overall data from systematic reviews and meta-analyses, but also when we're in the clinic, we should be thinking about it with each individual patient. And our goal is really meaningful remission, which to my mind is optimal functioning and quality of life for that individual patient. So what about lithium? That's a background about bipolar disorder, about treatment. What about lithium? Well, the first thing to say is that nobody owns lithium. It's you can see the third element in the periodic table here. It's been around since the dawn of creation. It's an element. It's actually present in the environment. It was discovered a couple of hundred years ago in Sweden and was used medicinally in treatment of things like gout. And there's a case series, history of it being used in Sweden and Scandinavia in the late 19th century for some mood disorders. However, it was banned by the FDA because of toxic side effects in the 1940s, but reintroduced, and this is a slide from my friend, Professor Daniel Smith, when he was at Glasgow, he's now in Edinburgh, reintroduced by the work of this man, Dr. John Cade, who published this paper in the Medical Journal of Australia in 1949. Now, Cade had done animal work. He'd given guinea pigs lithium and found that they were sedated. In actual fact, they may well have been toxic. But he then went upstairs in the Royal Park Hospital in Melbourne, which is now closed, and gave lithium salts to manic patients. And he reported not only the benefits of lithium, but the fact that the sedative but non-hypnotic effect of lithium salts reported in manic patients is so specific that it leads to speculation as to the possible etiological significance of a deficiency in the body of lithium ions in the genesis of this disorder. So not only was it suggesting a treatment role for lithium, but also a role for lithium in the pathogenesis of severe mood disorders. Now, the baton was really passed to this man, Mogens Schou, Danish psychiatrist, who actually did groundbreaking work in terms of establishing lithium as a treatment. You can see one of his early papers here with colleagues from Europe. Schou did what we would now call experimental medicine to establish the dose and did the early trials of efficacy of lithium. Personally, I think that Cade and Schou together would really have been very worthy recipients of a Nobel Prize for medicine. So important was the discovery, reintroduction, and establishment by Schou and colleagues of the basic scientific facts about lithium. However, there was quite a lot of negativity about lithium coming from the hospital that I now work in. Professor Michael Shepherd, a very famous psychiatric academic in Maudsley, produced a paper in The Lancet in 1968 entitled Prophylactic Lithium, Another Therapeutic Myth. He did this with a young psychiatrist called Barry Blackwell, who was a young psychiatrist then. Blackwell was also notable because he was one of the first people to describe the cheese reaction with monoamine oxidase inhibitors. And Shepherd returned to this, and he was supported in this by Professor Sir Aubrey Lewis, who was then one of the most influential people in world psychiatry. And I think this is one of the reasons that perhaps lithium wasn't taken up more widely. So there was a yang to the yin of Schou and Cades from Shepherd, Lewis, and others. However, that's not the position that we're in at the moment. Despite the previous literature of lithium water, it's now the gold standard benchmark for treatment. I'll talk about the evidence for that and about the journey from Shepherd's criticism to present day. Lithium has about one third of people with bipolar 1 will show a very good lithium response, 1/3 will show a partial response, and 1/3 will show no response. And that's different from other mood stabilizers. Clinical predictors account for some of the variants, but there's undoubtedly strong genetic factors. If there is bipolar disorder in the family and the lithium response in the family, then that's likely to pertain to the individual who's getting it. So there's a family history of treatment response. But on the negative side, there's a narrow therapeutic index, concern about effects on the kidney and so on. But recently, we've also come to understand from the literature that it reduces suicide rates, and I'll talk about this during my lecture. So, in terms of the evidence, lithium prevents manic recurrence, but it's less effective against depression acutely. But the meta-analyses now show that lithium is effective at preventing relapse into depression. So it's a true mood stabilizer. It's anti-manic, antidepressant, particularly in long-term maintenance treatment. It is effective probably only in about 1/3 of patients as full lithium responders, probably about another 1/3 with partial response, and that's in monotherapy. And there's a 1/3 who show little response. Narrow therapeutic index and long-term renal effects remain a concern. Particularly this is true with the kidney. Now, Professor Janusz Rybowski from Poland, who's a very good friend of mine, has got patients who've been on lithium for over 40 years with preserved renal function. There's undoubtedly other effects on renal function in people with bipolar disorder, such as cardiovascular risk factors and so on. but it does remain a concern. But good therapeutic monitoring, such as has been done in Professor Rabowski's clinic and reported data from Sweden, undoubtedly reduces the risk of renal problems. The benefits are not specific to bipolar disorder. There are powerful benefits on major depressive disorder. Now, this was shown most recently in 2017 by a paper from Professor Tiainen from Finland, where in the Finnish medical records system, the drug which was associated with the best outcomes in unipolar mood disorder in terms of hospitalization rates being the lowest was lithium. It was actually higher if you were on lithium and antidepressants. But the mechanism of action and time course of effects remain uncertain. Lithium probably reduces the risk of suicide, both in trials and environmentally. So in trials, it's quite clear, and environmental lithium effects reducing suicide rates on a population basis, to my mind, are now quite clear. And there's certainly work, most prominently the work from Brazil, from the group of Ferlenza and colleagues in Sao Paulo, that it may reduce the transition rate from amnestic MCI to dementia. Now, this is not surprising. We don't really know the mechanism of action of lithium pharmacologically, but we know it's a GSK3 beta inhibitor, and that's one of the putative pharmacological mechanism of actions that people have investigated as causing benefit for dementias. Okay, so I've talked about all of this. Now here's the Cochrane meta-analysis. This has been updated recently by colleagues in Germany, by Emmanuel Severus. But essentially, there was a debate flowing on from Shepard's criticism of lithium being a toxic placebo to Joanna Moncrief, who resurrected this in the 1990s. But then a series of trials, big trials done in the 90s and early 2000s, where lithium was used as a comparator drug in placebo-controlled studies to the new antipsychotics. And you can see overall that lithium does reduce relapse rates in bipolar disorder. And we now know that this is true not only for relapse into mania, but also for relapse into depression. So lithium's made the journey from John Cade giving it to guinea pigs in Melbourne right through to verification of the clinical benefits using meta-analyses. Prevention of suicide, that's also been shown. Now, these are the studies here. This is the clinical trials. There's a clear effect favoring lithium reducing suicide. Now, remember that this is when you're on lithium. If you suddenly stop lithium, there'll be a rebound, a likely rebound mania, but also a rebound in suicidality. But nevertheless, if you're on lithium and you're taking it, the risk of suicide is reduced. My own view is that this is due to a reduction in impulsivity, which is a key component of death by suicide, and also may be related to effects on frontal 5-HT2 receptors, where we know there's a functional antagonism of lithium. And we know that these are increased in post-mortem brains from people with suicide. Now, how do we define lithium response? Well, this is the ALDA scale, which was done by Martin Alda and Paul Groff, both Czech psychiatrists who work in Canada. You can see there's a number of components here. Criteria A is used to determine the association between clinical improvement and treatment. The rating should apply to the period of treatment considered adequate in duration and dosage. The illness activity should be judged by the frequency, severity, and duration of episodes, and it's from no change or worsening through to complete response. Criteria B, these are used to establish whether there's a causal relationship between the clinical improvement and the treatment. And you can see the number of episodes off treatment. 0 is 4 or more, 2 equals 1 episode, and so on and so forth. Frequency of episodes off treatment, duration of treatment. Bear in mind, these are long periods of time. So lithium treatment, in terms of lithium response, shouldn't be judged on a snapshot of a few weeks. We think it's really something that should be judged over 1 or probably better 2 years. Compliance, concordance, adherence, call it what you will, the patient taking their medication. is an important factor. This is judged including excellent to poor, and the use of additional medication. So none to systematic use of antidepressant or antipsychotic. And this gives a total criteria B score, and the total score is to subtract B from A. So this is the best that we've got at present in terms of determining lithium responsivity. Now, what we would like to do, excuse me, is to replace this with biomarkers. Biomarkers have revolutionized the treatment of cancers, and they've become very important in autoimmune diseases and many other areas of medicine. The National Institute of Health in the United States, the biomarkers definition working group about 10 years ago, defined biomarkers as a characteristic that is objectively measured and evaluated as an indicator of a normal biologic process, pathogenic process, or a pharmacological response to a therapeutic intervention. So you might say that this could be a measure of lithium response, could be something measuring a pathogenic response in bipolar disorder, or a normal biologic process, which was important for those two. And there's a time range, really a process from discovery of the biomarkers, identification, confirmation, validation and refinement to the adoption and clinical use. So a very good, simple example to my mind is estrogen receptors in breast cancer. We know now that if your breast cancer has estrogen receptor antagonists or estrogen receptor modulators are used, and if you don't have estrogen receptors on the pathological tissue, then they're not used. And this is actually a neat example, to my mind, of how biomarkers have changed treatment in oncology. So biomarkers are measurable and quantifiable biological parameters which serve as indices for health and physiology assessment. So this includes risk, disease risk, and diagnosis. So prior to treatment, if we have the biomarker, we can intervene, for example, with estrogen receptor positive breast cancer and determine the completed trial. So the biomarker is taking a baseline, measure of change, a surrogate endpoint, evaluation of benefits and harms, and then the clinical endpoint. And if we think about how this might be done, this is rheumatoid arthritis, but this group here could be bipolar disorder or MDD or many other psychiatric groups where the patient presents with the disease, but they're really a mixed bag of people who may or may not respond. So for example, red may be lithium responders, blue may be partial responders, and yellow may be non-responders. And if you have a predicted biomarker, you can then allocate the right treatment first time. So we could perhaps, if we had biomarkers, identify the lithium responders early on and treat them. If we had other biomarkers that suggested you should use other treatments, they could be directed down other routes. So this is a general scientific approach, which is paying great dividends in other areas of medicine and should be applied to the severe psychiatric disorders. So we're doing that. This is the R-Link study, which is funded by the European Commission. This is multi-center throughout Europe and is aimed at optimizing response to lithium treatment through a personalized evaluation of individuals with bipolar I disorder. So the goals for defining the markers of likely success with lithium therapy and its mechanisms of action. So as I've said before, lithium has a narrow therapeutic index, so we want to avoid exposure to serious side effects for predicted poor or intermediate responders. The time waiting for a response is important in terms of health service funds. We could make savings by predicting the patients who would be intermediate or poor responders, and they may get other treatment during that time. And a better knowledge and understanding of the mechanisms by which lithium acts within the biological milieu of patients to to produce excellent or intermediate responders, may help us develop new treatments. It may help us avoid unwanted side effects, and so on and so forth. So where are we with ARLIC? Well, before this, and indeed currently still, there's no biomarker available because of the lack of prospective studies. The outcome is unpredictable. Empirical approaches are used where different treatments are tried almost willy-nilly. There are costs, a high professional academic costs, impairment, relapses for patients, hospitalizations and so on. And there's a vicious cycle, which clinicians know well, of relapse feeding upon and leading to more relapse. Lithium exposure is poorly controlled. In fact, lithium use is dropping everywhere, and there's poor adherence. So where do we want to go? Well, we want predictive and personalized approaches that allow the early detection of responders versus non-responders. We want early stabilization of mood. We want optimized monitoring of lithium exposure. So this is much more fine-tuned with area under the curve being done. We want to enhance patients' autonomy and agency to allow shared decision-making. We think that this would help lead to improved adherence. It may well prevent disease progression. And of course, we wanted to involve patient organizations in our research. In the UK, this was Bipolar UK, and across Europe, it was GAMIA. So we were successful, and my friends in Paris, Professor Franck Olivier, Professor Bruno Etan, colleagues in Germany, Professor Michael Bauer, colleagues in Sweden, Denmark, and so on, we all worked together to produce this grant aimed at optimizing response to lithium treatment. And we were successful in 2020, gaining 7.7 million euros. And the aim is to identify the criteria that would make people eligible for long-term treatment with lithium and bipolar disorders in terms of response, safety, and tolerability. And that this should be transferable to clinical practice in order to improve relapse prevention, acceptability, and to avoid useless empirical lengthy trials of treatment. So what are the biomarkers that we're looking at? Well, as I said earlier, there's like to be a genetic component. So we're looking at the pharmacogenetics. Professor Thomas Schützer, who splits his time between Germany and the United States from New York and Munich, is helping with the pharmacogenetic studies, as is Dr. Anna Maria Catano from Brescia in Italy. And we have a work package devoted to this. We're looking at the molecular signature of the effects of lithium pharmacologically before and after lithium initiation. One of the perhaps most exciting aspects of this research is looking at the distribution of lithium in the brain. We know that the serum or plasma levels poorly reflect the central nervous system distribution of lithium. Dr. David Cousins in Newcastle has published papers already where he can measure brain lithium, and this is a key component. It may be as simple as lithium responders being the ones who get adequate levels of lithium in the brain. And we're also looking at actimetry. Actimetry, I think, is very exciting to measure activity levels, sleep, diurnal variations, and so on. And there's a whole program at that. And we're looking at ecological measures using smartphone-based assessments to try and improve adherence and compliance. So here's our main partners. And if we go from France round, we have Franck Olivier, Mary Claire, Bruno Etan, various other colleagues who are listed here. In Spain, we have Vieta and Colom. We have Acobiome for microbiotic element. We have Professor Paolo Brambilla from Milan. We have Anna Maria Catano from Brescia in Italy. Germany, we have Michael Bauer from Munich, Thomas Schützer from, Michael Bauer from Dresden, Thomas Schützer from Munich, Professor Reif and Professor Weissa from Frankfurt and Mainz. Poland, with Sweden, Gothenburg, Mikael Landen, Norway, Ole Andreasen, Denmark, Professor Lars Kessing, and in the UK, We have David Cousins and Jan Scott in Newcastle, and myself, Paul McCrone, Becky Strawbridge, and others in London. And you can see the various different partners here. So here's our study flowchart. Now, I was asked by a patient this morning, what were the chances of getting lithium in R-Link? And the answer is 100%. This is not a randomized controlled trial. Everybody goes on lithium. So they have the entry criteria are someone with bipolar 1 disorder who the patient and the clinician think may respond to lithium. And so therefore it's an observational cohort study rather than an RCT. So after the person is entered, there's blood sample, MRI, lithium introduction, titration. After 12 weeks of lithium initiation, more blood sampling for the molecular signature technique. Biomarkers are collected here. And then we have the lithium measurement in the brain with the lithium MRI, MRS. Then we have an enhanced adherence program, salivary self-monitoring with the ecological phase with optimization of lithium treatment, and the end point where we judge response, partial response, or non-response is at 2 years. Now, this is a rather complex diagram, which I won't go through to a great extent, except to show that everyone is very much involved. Coordinator is Professor Franck Belivier in France, and you can see different work packages, including our own work package down here, which I'm very ably assisted by Dr. Rebecca Strawbridge. Recruitment is going quite well. Of course, it was derailed with COVID, and we're asking the European Union for an extension. But I think we will get this because this is a fundamentally important study for psychiatry. Now, it's worthwhile pointing out that the successful funding of R-Link occurred in the context of a call for biomarker approaches to the whole of medicine, and only about half a dozen grants were funded, and this was the only one in psychiatry. So this is actually a crucially important study for our discipline. Now, this is the adherence package. This is the Monsenso system that comes out of Copenhagen. It involves smartphones, self-assessment and monitoring, visualization and feedback. The care provider has an overview of the patient data, which you can see here, including things like mood forecasts, the state, and so on and so forth. And then there's a configuration and feedback. Actimetry is done here, and you can see Jan Scott, Bruna Tan are very involved in this. There is preliminary work and some work done by, again, by Kathy Merrikangas, who's spoken about this, for example, at our recent ISAD meeting in Milan, where you can get a fairly good measure of the mood state, where you see this is euthymia, reduction in movement with depression, and an increase, particularly evident with the comparison between depression and mania in mania. And I think actimetry, actigraphy, call it what you will, is actually likely to be a very important clinical tool in the future, particularly in mood disorders, but particularly in bipolar disorder. Here's David Cousins' work on the lithium MRS. Preliminary work has been published. The great effort is to make the technology practicable, and David's done that. He heads up the MRI Centre in Newcastle, where I used to work, and does that very well. And you can see there's already a suggestion that there may be different higher brain levels of lithium in excellent responders versus poor responders. Now, in the 15-centre study like this going on across Europe, there's a huge amount of work to make sure that everything goes to plan. And you can see that the recruitment sites feed into the acquisition, data collection, harmonization, and processing, different work packages, data collection, analysis, and publication. So this is all underway. We've got, of course, no results of this yet, but hopefully we will get results in the coming period of time. In R-Link, we're going to do a testing of a prototype biological tool, which will be tested in a prospective validation study to measure lithium levels. The MRI pattern of activation before and after the introduction of lithium will be tested to see if this predicts long-term efficacy and tolerance. The brain lithium distribution, brain region of interest concentration measured by MRS. So this is functional MRI and this is MRS, and we'll see if the brain lithium concentrations can predict long-term efficacy. And there's qualitative and quantitative evidence being gathered about acceptability and efficacy of connected ecological devices to monitor salivary lithium levels and improve lithium adherence. So what we are aiming for is a multimodal marker that integrates all baseline variables, clinical, omics, and imaging between week 0 and week 12 to give the best guess at the probability of response. So it's really a panel of biomarkers likely to be the outcome rather than one biomarker, although it could be just as simple as brain lithium levels. The prototype of the home-based device for salivary lithium determination will be tested. There'll be an in vitro biological tool to screen novel mood stabilizers, and the economics of the stratified approach will be modeled. So that's R-Link. In the last few minutes, I want to talk about lithium and suicide and the putative effect on dementias. And then I'll round up and be happy to take any questions. So as I said, lithium, of course, we think about it as a drug, and we've done RCTs, but it is an element. It's available in water. It's in everyone's environment to a greater or lesser extent, but from lithium-bearing groundwater, it tends to get concentrated in the human food chain. And this is particularly so because, for example, if there's lithium in the water and this is used for cooking, lithium gets concentrated in, for example, green vegetables. So lithium is available in the environment, and it does vary quite greatly in terms of levels. Now, this is never more than a fraction of a percent of the amount that we give in clinical studies, but remember, this is on a different time frame. So for a stable population exposed to lithium in the environment, this will potentially start at conception and go right through to the full development of brain structures in the adults. And we know that lithium does affect, in experimental animals and in human studies, grey and white matter. So it's entirely plausible that if you're born in a low lithium environment and live your life there to your full brain development, and indeed possibly to the risk period for developing dementia, you will have a different brain from someone who had a similar stable exposure to high lithium levels in the environment. Now, it's now quite clear that environmental lithium does affect suicide rates. So the initial studies from this were done in Texas and were seen as a curiosity, but there's big studies in Austria, Japan, and so on. And this is our meta-analysis published in the British Journal of Psychiatry about the relationship between environmental lithium, higher environmental lithium being associated with lower suicide rates. And you can see that that's really now quite clear, certainly in males. Now, since we completed this, there's been a further study from Japan, which also goes the same way. So this is now quite a clear-cut result that in stable populations exposed to higher levels of lithium in the environment, the rates of suicide are lower. There's also the effect on cognition. Now, one of the first studies about lithium and bipolar disorder was about cognition in 1975 by Dr. Worrell from Glasgow. And from that time, there's been a suggestion that lithium may actually impair cognition. I think that's really not true. And there's an effect on lithium stabilizing the mood and therefore reducing perhaps processing time. Now, in terms of the pattern of mood impairment, cognitive impairment in bipolar, this is work from Katie Burdick in Harvard, and she's followed this up with far greater numbers. You can see bipolars tend to be intermediate across processing speed, attention, vigilance, working memory, and so on, between schizophrenia and bipolar. But the schizophrenia and healthies, rather, but the bipolar group is probably composed of three subgroups, one that maps onto healthy controls, one that maps onto schizophrenia, and one that's in the middle. And the question's always been as to whether lithium helps or hinders cognition. Again, Katie Burdick has published a paper very recently about this, which I think is instructive. This was a clinical trial, open label, a bit like RLink, 262 patients with bipolar 1, lithium monotherapy for relapse prevention. There was an association of lithium with better cognition at baseline and prospectively. So those that took lithium seemed to improve on their cognitive function. So in the baseline comparisons, patients already on lithium outperformed other groups in terms of verbal learning, and there were also numerically greater scores in verbal memory, executive skills, and global cognitive index. So the suggestion from Dr. Worrell in Glasgow from all these years ago that lithium was impairing cognition wasn't borne out. And in terms of the prospective comparisons, this only included those who achieved mood stabilization after being optimized in lithium. But there was significant improvements reported by Burdick and colleagues in the global cognitive index and verbal memory, very importantly in executive skills, something that people with bipolar disorder really complain of, the impairments in executive function. You can see the data here with the improvement from baseline to follow-up. What about dementia in the last few minutes? Well, the group in Sao Paulo, headed by Gataz with Forlenza and so on, leading it, did a wonderful study which has carried on over the past decade or so, where they gave people with amnestic MCI low levels of lithium and charted the progression to dementia. This was a placebo-controlled comparison. Now, the blood levels of lithium that were induced in this study are really quite low, between 0.2 and 0.4. But you can see the progression to dementia in this paper, quoted here from British Journal of Psychiatry, is lower. And this, of course, requires replication and further trials. But if this were any other drug, major funding agencies, such as the MRC, the European Union, National Institutes of Health, would be looking at big trials of lithium in this area. But for some reason, perhaps because of stigma and prejudice against lithium, this hasn't happened, and that's a crying shame. So to conclude, lithium in the 21st century is the same as lithium in the first century, or indeed 4 billion years ago. It's an element, not a medication. We study it as a medication, but we may have been looking at it in the wrong way, especially thinking about it in terms of 8-week trials or 12-week trials or even 6-month trials. We really need to look at lithium response over the course of about 2 years, as we're doing in RLink. The clinical use of lithium, I think, would be revitalized by biomarkers. Lithium has a declining use. It's dramatically declining in the United States. It's declining in the UK and across Europe. There are some countries and some, particularly academic psychiatrists like us, who use it, but generally young psychiatrists eschew using lithium, and that's a great shame. But if there were biomarkers, it could give the patient a much clearer metric of the likelihood of response. That would revitalize the use. The interaction between environmental lithium exposure, brain development, and mental ill health should be studied further. Seems to me that this is absolutely key. We do have natural experiments in South America where there are relatively stable populations who live in low versus high lithium environments who could have really detailed, deep phenotyping and genetic, epidemiological, and pathophysiological studies done. But that would, of course, require funding from major funding agencies. Lithium reduces suicide in randomized controlled trials. I think that's quite clear, but also environmentally. And I think the environmental lithium effects, we need to understand this better. And there's lots of work going on with this. We need a better proxy measure of lithium apart from drinking water. And we're currently doing studies in the Ukraine with colleagues there to try and look at the effects, the correlation between lithium and wastewater and regional suicide rates. As opposed to the common notion that lithium may impair cognition, lithium may benefit cognition, and the paper of Dr. Burdick and colleagues is very interesting in this regard. And lastly, relatively small trials, but greatly to be applauded trials, particularly the Brazilian trials, suggest that lithium may reduce the risk of dementia, particularly progression from amnestic MCI, but we really need further large studies to do this, and it's a crying shame that none of these have been funded. We have written them and applied for the money, but and sometimes the funding agencies have granted the grants on condition that lithium is taken out, which is astonishing. I'll stop there. Thank you for your attention and look forward to any questions. Tesha Kudanam.
Thank you very much, Professor Young. I think we are moving towards an age where we will regard lithium as the golden standard again, as one of the recent Lancet papers imply. And I would like to ask our audience if there are any questions. Evet arkadaşlar, Profesör Young'a sorusu olan var mı?
Any questions for Professor Young?
I have two questions. First question is, what should be the therapeutic level of lithium in the prophylactic treatment of patients with recurrent depression, unipolar depression? The second question is, we have young patients in their 20s or early 30s. Some of them has history of family history of bipolar disorder. One or two family member has bipolar disorder. But our patient is only unipolar. They have recurrent depressions, but they have a history of family history of bipolar disorder. We take no response from the first or the second antidepressant treatments, so we don't see any hypomanic or manic episodes in these patients. So when should a mood stabilizer be started in these patients? When you see no hypomania or mania?
Okay, well, thanks very much. And those are great questions. If I can start with the general issue of lithium in unipolar mood disorders, I would refer you to the Lancet Psychiatry edition in 2017, where I wrote an editorial commenting on Professor Tianen's study in Finland and highlighted the evidence about the use of lithium in unipolar disorders. So just to reprise, Tianen looked at the medical records of people in Finland, and the drug which was associated with the lowest rehospitalization rate in unipolar disorder was lithium. And that was actually lower if you were on lithium alone compared to lithium and antidepressants. So that's noteworthy. The other thing to say is that, as I summarize in the editorial, there are actually trials of lithium as a prophylactic agent in unipolar disorder. And the meta-analyses show that they're broadly comparable, if not better, than antidepressants. So I think it's very valid to use lithium in unipolar disorders. We tend to reserve it as an augmenting agent for people who haven't responded to antidepressants. But nevertheless, I think you could even use it as monotherapy. You can certainly use it in combination with other drugs. Now, the question is when should you use lithium? There's some evidence that using it earlier in illness progression is better. So there's a study from Melbourne, Australia, from Michael Burke and colleagues showing that first episode people tend to do better on lithium and have a bigger effect size. So I would certainly think it's reasonable to think about using it early in that patient group, especially if there's a weighting towards bipolar disorder from family history, disease characteristics, and so on. But also, remember in the BALANCE study, which we published a few years ago, these were patients who had by definition failed on lithium or failed in valproate, were then randomized to the combination or to lithium or valproate. The lithium group did really well. These are people who are supposed to have failed lithium. So I would think that you could use lithium early, you could use it late, as in after many episodes, or you could use it anywhere in between. I think it's always a valid treatment option, including for unipolar disorders. Thanks for the question.
Okay. Teşekkürler.
Thank you.
Buyurun Kazım Hocam.
Mr. Kazım has a question.
For the excellent talk. It was very informative for us. I have a couple of quick questions. Are you also looking at the predictors of side effects, or biological markers of side effects, possible side effects? Second question is that maybe you mentioned, but I missed, how did you interpret the lithium MRI findings?
Okay.
My last question is, when do you expect to finish? When do you expect the study to be finished? And the last one, a little bit personal question. When you see first signs of the kidney impairment in your patients, what's your treatment strategy? Thank you very much.
Okay, great. Well, that's four great questions. So the first one is, yes, we're measuring predictors of side effects in R-LINK as well, so that's very important. So that's question number one. Question number two about the brain scans is we're doing two different types of things. We're looking at fMRI activation, and we're using MRS to actually get lithium levels in the brain, in the CNS. But that requires a 7 Tesla MRI machine. So we've got a subgroup of R-LINK centers doing that, about half a dozen. But we will actually get a measure of brain lithium levels, a bit analogous to the measure that we get in the blood, for example. How long will R-LINK take? Well, I expect to get our first cut of data in about three to 4 years. Given that we have a 2-year assessment window, given we're still recruiting, we're anticipating finishing recruitment perhaps in the middle of next year. We're trying to get an extension to go to the end of next year. So really, we'll be talking about R-LINK for a long period of time, but we would expect the first data around about then. Lastly, what to do about the kidney side effects? Well, my strategy with this is, firstly, I use EGFR. If necessary, I'll do a full urine collection, but EGFR is pretty good. There's a nomogram for normalizing it to the population. I like to chart the EGFR. So we measure it frequently in patients, we chart it. We very often find actually reducing the lithium level, even a marginal amount, actually produces a benefit in EGFR. So we do get a fluctuation. So we chart over time, we cautiously reduce. My own belief is that you're always better off with some lithium than no lithium. So, I mean, if there's real problems with the EGFR, I'll go down to lithium levels of 0.4 or 0.3, but try and keep the patient on some lithium in combination with other drugs. But I think combining it, charting it, looking at it serially over time, and it does recover. I mean, it's quite interesting in that, you know, it will fluctuate even without changing the lithium levels. So you shouldn't make a decision based on one EGFR unless it's very dramatic. Another thing is we speak to our kidney specialists, our nephrologists, who, in my experience, are always very helpful with this. It's good to build a relationship with a nephrologist if you're interested in lithium. Thank you for 4 excellent questions.
Thank you, Professor Young. Buyurun Serhat Bey.
Dr. Young, thanks for your excellent presentation. I want to ask, could you please explain a little more what you mean by saying lithium is an element, not a drug?
Sure. Well, I mean, I guess it's a bit like calcium. You know, one of the important things about lithium is that people manufacture lithium carbonate and we use it as a drug, but it's also in the environment like zinc or hydrogen or so on. So I think we've done medical studies where we've done trials, but also lithium is in the environment. And you know, there are all across the world, including in Turkey, there are spas which were famous for their healing benefits, and they usually are the places that had high lithium in the water. Now, this is not unique to just Turkey. This is true in the UK, the US, and so on and so forth. So we must think about it in both ways: an element and a drug.
Thank you, Dr. Young. Any other questions? Başka soru var mı arkadaşlar? May I ask you what is your choice of lithium dosage in treating patients? This is probably a very elementary question, but there are discussions whether to keep it high, near 1, or keep it low so that side effects are low. What is your personal approach and your team's approach?
Well, I think if you're treating acute mania, you might want to go to a level of 1, but for maintenance, the level should be 0.6 to 0.8, because that's the best for the kidney. So 0.6 to 0.8 millimoles per liter. You don't get the antidepressant effect until it's 0.6. I do have some patients who don't tolerate 0.6 to 0.8, and I have them on 0.4 or something like that, but the best range for long-term treatment is 0.6 to 0.8 millimoles per liter.
Başka soru var mı? Thank you very much, Professor Young. It's been a great pleasure hosting you here with our applause. Thanks very much, and we hope to see you in person next time. Hopefully, inshallah, in Antalya.
Teşekkür ederim. Thank you very much.
Thank you. Bye bye. Thank you. Evet, çok teşekkürler katkılar için.